Good afternoon. I'm Dr. Liesl Bryant, and I'm one of the risk management advocates for the Trust. I'm delighted that you're able to join us today for our 29th Risk Management Roundtable. As a Trust policyholder, most of you are likely familiar with our risk management consultation service, the Advocate 800 program. It's one of the many benefits our policyholders receive through the Trust. I'm one of the 8 advocates, and I'm excited to be joined by 2 of our other advocates today, Dr. Joe Scropo and Dr. Jeff Youngren. So on that note, we're going to go ahead and get started. Thanks to Dr. Youngren and Dr. Scropo for joining me. And let me just pull this up. Okay, so Jeff, I am going to start with you. As you know, we get lots of questions around issues related to the complexities between forensics and clinical roles, right? So can you start maybe by just helping us distinguish, how does one distinguish or determine whether it's a forensic or clinical role, and why does that distinction matter so much from an ethics and risk management perspective?
It's a great question, and it's a common question we get in our consultations with our insureds. The first thing that's important is to understand what is forensic psychology, what it does. And forensic psychology is that part of our profession that addresses criminal, civil, or administrative issues, answers questions about those. It is a profession that wraps itself around questions that have psycholegal meaning, as opposed to people who are involved in psychotherapy. Their job is to further the interests of the patient and treat their psychological condition. So those are treatments. Those are things that are direct deliveries of mental health services to individuals. And so you really need to understand the differences between those, because the shift from one to the other is considered to be a shift in role and potentially a role violation when you usually walk from a clinical service into answering a psycholegal question about a patient having disability or being psychologically injured, or writing letters of attestation about that. When those things don't have anything to do with the clinical job of treating a patient. It's advocacy, and I believe that good therapists are advocates for their patients. But when you have that kind of question that comes up, you need to be very careful about whether what you've been asked to do really has anything to do with treatment. Write a letter, testify in court, testify about disability. Those are psycholegal questions. In the short term, psychologists can, of course, and are allowed by law to render short-term disability for patients who can't work. But that's a gray zone area. And it's an area that has some significant risk about it. So we recommend that individuals who disable patients only do that for short term, for acute circumstances, and then let that question go off to somebody else who will answer the long-term issues about disability and damages, so you retain your role as a treating therapist. So this is a constant question. Lawyers want me to write a letter. My client wants me to write a letter. Um, what does that have to do with therapy? It's really advocacy that's kind of jumped off the tracks, and that has significant risk for the practitioner. So if you don't know whether you should be doing something, we teach over and over, consult. You can call the service here, and we'll happily chat with you about whether that is something that's gray or black and white, and how dangerous that behavior may be. But advocacy outside of the treatment room is really dangerous advocacy.
Yes, great. Thank you, Jeff. You made a lot of really great points. Joe, anything to add on that?
Well, just the one way to know that you're being drawn into a forensic role as a therapist is if you're asked to take an action that's going to have an impact outside of the therapy room, where the kid goes to school, child custody, disability, emotional support animals. Anytime that what's at stake is something outside of the therapy room. That's when your red flag might want to go up and say, am I being pulled into a forensic role that isn't really suitable for me, or I need to think it through very carefully before I engage in whatever is being asked of me.
Yeah, that's another great distinction. And I think, Jeff, back to what you said, when it's gray and or when you don't know, consulting is a great thing to do, right? Because there are some ways to sort of thread the needle, as one of our colleagues often says, maybe writing a statement that sticks only to the treatment facts, for instance, but doesn't address the psycholegal matter. But there's pros and cons to that too. So to your point that it's gray. So, all right, we'll probably get more into that. I already see a few questions in the Q&A, so we'll come back to that in just a few minutes. Before we do that, Joe, I want to go to you with a question. This is also one of a very difficult situations that clinicians often face and call in about, and that is having a client who is suicidal. So if we take, let's make it an especially complex scenario and say that a clinician has a minor patient, say 17-year-old, who expresses suicidal ideation. Can you say something about sort of what the clinician needs to be thinking about and or maybe some steps they should consider taking in that kind of a situation?
Sure. So just some quick information about teenage or adolescent suicide. Some people think that young folks are not at any particular risk, but it's the second leading cause of death among people 5 to 24 years old. So it is a significant phenomenon. It's something to pay attention to. Fortunately, about 80% of folks who in that age group who attempt suicide are giving clear warning signs. So that's the upside of it, that if we pay attention and can catch those, we can intervene. The second thing I want to talk about is the standard of care. I often get the sense that therapists define a failure when the patient suicides. I failed. And that's not correct. That's not accurate. What do we take to bring an action, a successful action against you for patient suicide would be that you deviated from the standard of care, meaning you did something that, or you didn't do something that an ordinarily skilled member of our profession would do. So deviating from the standard of our profession is what puts you at risk. And also that deviation, that falling below is a proximate cause, is a direct cause of a patient's suicide. So it's important to get that clear for yourself that you cannot prevent a person from committing suicide who's determined to. What you're going to be judged by is, did I do an adequate job? And did I do what a reasonable psychologist would do? And if you did, then you're in good shape. So the second thing to say about suicide is that I think to get patients to talk about it requires reassurance on your part that they may have fears that you will immediately hospitalize them for disclosing that they have thought about suicide. So everything is predicated on having or trying to have some rapport and trust with the patient. And one way to do that is to discuss what you would do if a patient was suicidal or did express it. You wouldn't jump to hospitalization. You would talk about it. You try to understand it. And you may want to explain that to the patient, that it's common to have these thoughts and feelings so that it normalizes it. So you need to have some rapport. Otherwise, you're going to get nothing. And that's not going to help the patient. The third thing here is that what you want to do when a patient exhibits or reports suicidality is to conduct a comprehensive suicide risk assessment. You can do that by using some standardized instruments. The ones that have been found to be validated are the Columbia Suicide Severity Rating Scale, the Suicide Cognition Scale Revised, and the PHQ-9. Also the BECS, the Beck Suicide and Depression Scale, have some validity. So as soon as a patient appears to you to have suicide as some kind of relevant issue for them, it's wise to plan to relatively quickly initiate a comprehensive evaluation. You don't have to use the instruments. You can use a set of structured questions, but you need to do some detailed inquiry. It's important to ask directly about suicide and perhaps in a graduated manner. Have you ever wanted to be dead? And then, do you have current suicidal thoughts? And if the answer is yes, do you have a method that you've thought about? And if the answer to that is yes, do you have a plan? And ultimately, what is your intent? How closer are you? Do you feel you are to acting? So the very first step is to just directly ask in detail about suicide in a kind of graduated manner. If suicidal ideation is present for the person, you want to establish the frequency of that ideation, the duration, the controllability. Can the person forget about it, put it out of their mind or not? And what deters them when they have those thoughts? And these are things you would document in your assessment. The risk management in this area is essentially documentation. It's A, conducting the evaluation, B, documenting. Um, so general areas of inquiry, you want to know, did something currently happen that stressed the patient, that put them into this state? Did somebody die? Did they break up with somebody? Uh, are they facing homelessness or incarceration? So you may want to inquire about external stressors that could be operating in the background and aren't just inherent within the person. Um, some of the direct warning signs of suicide, and these are ones that would cause you to probably take immediate action, is that the person says they're suicidal, or they've written a suicide note, or they're strongly stating they wish to die, or you learn that they've made preparations to die. That would be another reason, giving items away. And third would be them seeking access to lethal means. If they're telling you that, or you learn that from collaterals or other people, those are high risk factors, and they may lead you to take immediate action that involve immobilizing the patient or having them evaluated further. There are indirect signs of suicide. I'll just go through a few of them. Previous suicide attempt is the strongest one. History of depression and other mental illness. Serious physical illness is known to be associated with suicide and suicide attempts. Criminal legal problems, financial problems, impulsivity. Substance use is a big one. If someone's currently out of control with their substance use, that is a definite suicide risk sign. Uh, have they committed violence or been a victim of violence? Another warning sign if the answer is yes. Social withdrawal, I think, is also a powerful indicator if they've moved away from their normal support group. That is another indirect and meaningful sign. There are also protective signs that you should be looking for, protective from some person committing suicide. So things like they're really afraid of dying and they tell you that, and I just couldn't do it. I just couldn't stand it. Or they can identify reasonable means for living that make sense and that seem genuine on their part. Strong spiritual beliefs may be another protective factor. Having a strong support network, um, having good problem solving skills, or feeling that there are reasons to live. If you ask the patient if there's reason to live and they can give you good reasons, those are protective factors. So after you've done that assessment, you determine the level of suicide risk. Um, Now, unfortunately, even the best tests, the best models, they're very good at identifying who will not commit suicide. They're not good. The state of the art for predicting who will commit suicide using structured instruments is very poor. It's about 1%. So at this point in time, we're really out there without a definitive way, an effective way of identifying who will go on to commit suicide. Okay, so you made your assessment. You want to determine whether the person needs immediate hospitalization or an IOP or a PHP. If they're not at that level of suicidality, you would then construct a treatment plan. And here's where the aggravating and protective factors are useful. So such social isolation may be an aggravating factor. So talking about getting the person into some kind of group setting, a 12-step group, or somehow addressing their isolation would help in formulating your treatment plan. So use the factors to to put together a plan based on what you found as protecting and putting them at risk. Then you elicit agreement on the treatment plan. You want to see if the patient's willing to do this. And if they are, you discuss what it's going to be. It could be psychotherapy. It may be involve referral for medications. It may be referral to adjunctive treatments, or you may feel that you're not competent to do it, and you may want to refer to a DBT therapist because you don't feel that you're up to doing it. And there's no shame in doing that. Be aware that a contract that used to be popular, I will not kill myself, these no harm contracts, they have zero value. They have no legal value. And in fact, they're found to potentially increase the risk because it's seen as an attempt to pass off responsibility by the clinician. I'm just having you sign something, so now I don't have to worry. So it actually increases the risk toward you. One thing that does work is a safety plan. And this is something you want to give to suicidal patients. There's a good one you can find online called the Stanley Brown Safety Plan. And it tells the person, the person writes it out. What are my warning signs? What are my internal coping strategies when I feel suicidal? Who are the people and social settings I can seek out if I'm feeling that way? What professionals and professional services can I seek out if I'm in a crisis? And what steps should I take to make the environment safer around me, i.e. get rid of lethal means in your immediate environment. So that safety plan is useful, and it's written, and it's something that would be wise to execute with someone who's suicidal, but you do plan to treat them. Other quick things are to coordinate care with other providers. That's really critical in protecting yourself. There's a psychiatrist, make contact and get authorization to speak, or at least communicate what you know about the patient to the psychiatrist. That will put another set of eyes on the patient, and you're not the only one responsible now for the patient's safety. Be prepared, know how to get to get the patient to an ER involuntarily, know in advance what numbers or how to do it. In this case, with the 17-year-old, a question you have to ask is, do I need to disclose it to their parents or not? Most of the time, something this serious would be something you would disclose to the parents. But if it's clinically contraindicated in a particular case because of what you've learned about the parents, then you may not. But I would say it would be risky not to do so. And finally, you want to treat and address comorbid illnesses, the depression or the physical illness, or you want to see that the person is getting treatment for the underlying psychological or physical factors that are putting them at risk. That's it.
Great. Thank you, Joe. You gave us a lot of good info. I see we have a couple questions, not getting into them, but they just wanted you to repeat measures. I think you mentioned the Columbia rating scale Q9. Is that correct, Joe?
Well, the suicide measures that have some assessment scales that have some validity would be the Columbia Suicide Severity Rating Scale. There's a screener version, which is quick. This is the Suicide Cognition Scale Revised. This is empirically supported. PHQ-9 also, and the Beck Suicide Intent Scale and the Beck Suicide Ideation Scale.
You know what, Joe? I'm going to interrupt you. I'm so sorry. Okay. Yeah, just so you know, Joe, your internet was really unstable there. We couldn't hear much of what you said. So maybe we'll come back to you, and or if someone could type those into the chat for us, that'd be great while we move on. I'm noticing our time, and I do want to get us to live questions pretty quickly here. So Jeff, I'm going to come to you. We've got a couple more quick questions. It's on the same topic, but let's try to maybe keep our responses to this as short as we can and succinct, and then we can do follow-up questions if need be. But Jeff, I want to start talking a bit about the also difficult situation when we are aware of other providers who may be engaging in unethical behavior or may be impaired and in some way practicing in an impaired way. And that's, you know, one of the very difficult situations we face as providers. So can you first speak to sort of what our code says about that in terms of informal versus formal resolution? And then also talk about whether or not we have a responsibility to investigate those matters if we learn of them.
Sure, briefly, this is a area that people get confused about a lot because in our ethics code there is a section that says that if you are aware of a colleague who is engaging in unethical conduct, that you can pursue formal or informal resolution of that. Or, in fact, there are state laws that frequently say that if you become aware of this, a patient, of a psychologist engaging in unethical or behavior or is in fact impaired, you need to report them to the licensing board. The problem here is that actually those administrative regulations don't trump the power of privilege. And so if that information comes to you from the context of a treatment relationship, it's simply information that's in the treatment relationship. You cannot go out and do something with it, even though the codes say that. And sometimes state laws will say you should report these things to the licensing board, when in fact the privilege and confidentiality laws of the state do not allow that to happen. So very quickly, if the information comes to you in the context of a treatment relationship, um, that is not something you can act on. It is confidential. If it is something outside of that, then you can make a choice about whether you need to report that formally to a licensing board for formal action, or in fact approach your colleague about those concerns like drinking or having those kinds of difficulties. May be appropriate for you to approach that person. But the real issue is where you get that information. And very quickly, second is you don't have a job to investigate anything. You're not a private detective to try and find out if there's more information that would lead you to a conclusion that an individual is impaired. That is, we run into this problem with child abuse reporting and elder abuse reporting. You are not an investigator. Your job is to report the information you have, consistent with the state law, and you are done at that point. So this is a common question that we get. So that's what I have.
Yeah, that's great. No, thank you. It comes up more commonly than we would hope it does,
It
right?
does. It does. We get lots of questions about that. And
Yeah.
people think they have to be an advocate for cleaning the professional house, if you will. Well, that's not your job. That's simply not your job.
Mhm. Yeah, Joe, can you add some pieces there?
Yeah, yeah. Can you hear me okay?
Now we can. Yep, that's good. That's good.
Okay. So, I mean, the common sources of impairment in our field, and typically the requirement where it's mandated to report applies to other healthcare licensees. So not just psychologists, but anybody licensed as a healthcare provider. So the kinds of things that impair are substance use, mental health conditions, burnout and fatigue, aging, cognitive decline. These things can account for impairment. Incompetence and antisocial orientation. Hopefully that's not common, but it probably does occur. Um, as Jeff was saying, states have different rules or no rules. Some rules have no mandates to report unprofessional conduct observed by you in other healthcare licensees. Other states do, the states that don't have those laws are New York, California, for example. Some states do have a reporting requirement, but not if the information about the impaired professional comes from a patient. So if you're treating someone who's an impaired professional in a state like that, you cannot report because the mandate only applies when confidentiality is not present. Finally, there are states that just across the board say that if you reasonably believe that a healthcare licensee is impaired, you must report, regardless of whether you're breaching confidentiality or not. Jeff went over the ethics code, and the idea is to try to resolve in minor or not so serious difficulties directly with the alleged offender. More serious violations or alleged violations may need to be reported, but to the board or some other action taken. Don't automatically assume your patient's telling you the truth. Just spend some time inquiring. And if your patient is psychotic and rambling, that may not be enough to trigger the mandate. Take notes on if you do are in a situation like this, make good notes about why you believe that you have to make a report and what the factors are. And if you do make a report, just give the facts. You don't know exactly whether someone's impaired or not. You don't want to be accused of defamation or ruining someone's career just because you blurted out a whole bunch of stuff without thinking about it. So you want to report just the facts that led you to believe that this person is impaired if you're mandated to do so. One other thing, in states where it's mandated to report, almost always there's an immunity provision so that you cannot be sued or suffer criminal or civil action against you as long as you're not doing it maliciously to hurt somebody else.
Yeah, great. Thank you. And I'll add here, I know we say this a lot, right? But this is another case where it's really, when there are questions or you're not sure what to do, it's really helpful to consult because it can help you understand, is there an actual ethical violation? Is this just a difference of practice? What steps should you take? Should you do informal versus formal, et cetera? So consulting is useful. And I also want to mention, I know both Jeff and Joe have noted the need to know the state law. I just want to remind us all that if you are practicing across jurisdictions, you have to know the state law where the patient is as well.
Yeah.
So not just your state. Yeah.
Yeah, I'd like to add one thing though. If you are in a state, I would argue that if you're in a state where the law mandates you have to report no matter what, then that's like a child abuse requirement. And I would argue that you need to give some thought about whether that should be in your informed consent, because you're taking the power of the controlling the experience away from the patient and complying with the law, but we can't surprise patients with things like, oh, I'm going to have to report that. If there are things that are mandates, those things should be an informed consent.
Yes,
Yeah, I
absolutely.
agree.
That's a great point. Yeah, I think we all agree. All right, so let's turn toward some of the live questions. And it looks like we're going to be jumping around a lot of different topics. So the first one is actually a topic we haven't talked on yet, which is great. But one question is, do you have advice regarding if ICE comes to your office? Joe, do you want to start with that one? I assume they're looking for patient records or that kind of thing.
Well, I mean, the first thing you'd want to do is challenge the officer to determine what legal authority they believe they have to enter. Uh, in order to enter a private space, they would need a warrant, a judicial warrant signed by a judge. In public areas, which can be a little fuzzy, there's not a need. So walking around the waiting room or in the building, that does not require legal permission or judicial authorization. You have no duty to cooperate with the person. You should be polite, of course, and you want to find out what they want and what they're seeking. You may want to verify their identity as well and have them show you proof of who they are so that you know you're dealing with an actual ICE officer. But you're not compelled to speak or disclose any information that to ICE agents. So be polite, don't say a whole lot, encourage them to leave.
Right,
Yeah,
Jeff, anything to add?
yeah, just a little bit. I think this is an area where you have to be very careful to separate your political opinions from the law. Joe is right about the limitations of what they can and can't do, but you may have some very strong opinions about ICE and the things that are going on politically, and it's very important to make sure that those are separated from your knowledge of the law and what they can and can't do. Like, are they allowed in the waiting room? They're not allowed in the treatment room. They have to identify themselves? Those are all fair questions, but because it's such a hot topic in our culture, you need to be very cautious about getting your personal feelings mixed up with all of this, which can escalate the situation and make it difficult to control.
That's a great point. Thanks for adding that. I want to note there's a couple questions here on the difference between being an advocate and a consultant, but it isn't really clear to me what the question is. So if you want us to try to address that, if you can write back in and make that question a bit more clear, that'd be great. Jeff, I'll send this one to you because it's about writing letters of advocacy. And the question really is, does writing a letter of advocacy have greater risk than simply releasing the progress notes, say if an attorney is requesting them?
The answer is yes. It's just another document that you've created, and if you're going to write a letter that's a summary of treatment, that's fine, but it is creating another document that exposes that document to whatever legal proceeding it might be going on. Your psychotherapy notes or your clinical records are, just that. They're a record of what occurred, and you can be questioned about those in deposition, and you can turn those over. But if you're going to summarize something, make sure you summarize and stick to the facts and don't render opinions about like causation. This caused that, or damages. My patient has difficulties sleeping because her boss sexually harassed her. Those are forensic answers. And those are forensic answers to forensic questions. You can say in your record, though, the patient reports that she is having trouble sleeping because her boss harassed her. That's fine. But opining about in a conclusory way about the fact that this incident did cause a problem is difficult. So be cautious if you're going to write a new document. Understand that that's an additional piece of information in the mix, and be very careful to avoid conclusions about psychological injuries related to that.
Joe, anything you want to add?
And that would extend to the records as well. You don't want to make conclusory opinions on legal issues in anywhere because that's not your role to do that.
Agreed.
Does a summary add something? A summary adds potential risk in a sense that if you're ultimately asked to turn over the records, your summary will likely be compared to the records. And there will be some opinion about your credibility based on the extent to which the summary actually comports with what's in the records. And don't use summaries as a way to hide, like someone's applying to the military and they have a request for records about that patient, and you offer a summary and they accept it, and you omit that the patient has a serious substance abuse history. Eventually the records may come to light and you're not going to look good in that situation. Second thing is that records are admissible in court as evidence when you certify them. You're typically going to be asked to certify a record. It's a standard form that you fill out and it's notarized. It says this is my accurate record, complete, made at the time or near the time of the action described. Summaries are not legally admissible in any situation. So lawyers if you're asked for these things by lawyers, it's kind of a waste of time to offer the summary. And you may want to ask if that's really what they want, or they'll know that the records are what's admissible. So you may feel that your offer is being rejected, but it's for a good reason, that it has to do with the admissibility of that material.
Yeah, I think summaries are dangerous turf. They're dangerous turf.
Yeah, I think there are risks. And one of the things I see a lot, and you guys probably do too on our calls, is that clinicians have this sort of automatic response of when there's a record request. Oh, I won't release my record. I'm going to write a treatment summary instead. And I think that automatic request is a problem. So I agree definitely with what you said. And this is another case where consult, right? Find that out, because it may be that your summary is actually going to create more of an issue than turning over the record. So, okay, Jeff, I'm going to start with this one with you. So the question here is, if you become aware of a psychologist performing psycholegal, or in this case, administrative evaluations, but failing to complete and submit their reports for upwards of 18 plus months after the eval. And it sounds like this person's saying, if you've attempted an informal resolution, what would you recommend in a situation kind of like that? We can't give specifics to any specific situation, but can you give a general in terms of informal resolution versus formal if you think there's a problem with a colleague?
Summarize that again, Lisa.
Yeah.
I'm not sure I
So
understand.
let's say you've got, you know, of a colleague who does administrative or psycholegal evals. They fail to submit their reports for upwards of 18 months afterwards. There's been an attempt to do an informal resolution, but the problem continues.
Well, I mean, first you're operating in the legal venue. I mean, 18 months. The first question that comes to mind is how current is that information? It's 18 months old. A lot can happen in the world for 18 months, and so the information arguably may not even be accurate. If informal resolution is a legal proceeding, if they're trying to resolve a legal matter informally, fine, they're entitled to do that. The evaluation is what the evaluation is. And so if you get deposed or asked to talk about an evaluation you wrote 18 months ago, I would advise you that you need to update your evaluation in order to make sure that the current events are reflected in that event in that evaluation. It's an old evaluation.
Joe, anything to add?
Yeah, I mean, what I would, the first thing that comes to mind for me is that I've seen this happen in forensic cases, and this sounds like a potential forensic case. The experts start fighting with each other, the ones on each side, and they begin to resort to considering board complaints against the other. I personally, other people may disagree. I don't think that's generally the right venue. There's a court, there's a trier of fact, there's a proceeding and a procedure to challenge bad data, false data, incompetent data. And I think absent extraordinary circumstances, we should not be using board complaints as weapons in forensic situations, unless it's truly something egregious. And I think it's important to quantify how serious is this alleged unprofessional conduct. Taking 18 months to write a report versus having sex with a patient is two very, very different kinds of harm. And although they're both harm, it may determine how you're going to respond and with what intensity you're going to respond and how you're going to proceed.
Yeah, no, also very good points. So Jeff, back to you were talking earlier, right, about when it's forensic versus clinical. This question here, I think, is going to that point, which is, does that also apply to filling out FMLA paperwork for patients?
It's a gray zone area, right? I mean, the question I would ask is, what does that have to do with psychotherapy? Um, and while you have the right to do that, much the same as you have a right on the short term to disable a patient, that if in fact an individual is wanting extended uh, adjustments in their lives based on psychological issues, that should be done by somebody outside of the treatment relationship. Because if it falls apart, if it falls apart, it'll become all you talk about in therapy. If you don't agree with it, that'll be all you talk about. If you do agree with it and we need to extend it, that's all you're going to talk about. So these administrative decisions on the parts of psychologists become problems that occupy a lot of the time in the therapeutic hour when they shouldn't. I will resort to my be careful when you wander into these areas. And Lisa was correct. Consult with people, see if it's within the scope of your practice to do that. If you're going to write a letter for FMLA, you need to know what the law says about that. So you need to have actually read the law. So people write all these things and they don't even know what the law says about it. So if you're gonna advocate in that way, and if you feel it's necessary clinically to do it, be informed.
Joe, any quick additions there?
Yeah, I mean, the typically disability letters or FMLAs letters, there's an actual FMLA form that is used that you can take a look at. Some of the information is pretty straightforward and something that a psychologist, treating psychologist could answer. The questions that get very difficult are, does this prevent the person from working? We don't have any opportunity to observe people work. And that the connection between the disability or the diagnosis or the impaired psychological functioning map is difficult to map onto work functions. So, and there's also something that I refer to as the tyranny of the form. It's that because it's there as written in a certain way, you got to answer it that way. No, you can say, I'd like to answer this question, but I can't. I don't have enough information. Or it will take, I'll have to, the person may not be able to function for a period of time, but after that, there should be a reevaluation. So you kind of can quantify your answers in a way that hopefully are factual information for the most part. And if you're going to make statements, you want to be cautious in what you say. Be aware that you don't have to follow the answer, the format of the question. You can say, qualify it or add an addendum. And this gives you a chance to elaborate. And often that will help you if you decide you're going to write such a letter. And the things you would write are that I did not do a disability evaluation. I am Mr. X's treating therapist, not an independent evaluator. And number three, the primary sources of information are my patient. And once you've used those disclaimers, that helps the reader put in context whatever it is that you say. And that's, I think, an ethical duty on our part.
Also good points. Okay, Joe, so I'm gonna let you start on this one. And I'm also going to sort of summarize this, but your comment earlier about when distinguishing clinical versus forensic roles and using the outside of the therapy room to sort of distinguish that. It looks like there's some confusion about, does that also mean if someone goes into a school to do an IEP or those kinds of things? So can you just clarify what you meant?
No, no, that's a great question. But I was speaking metaphorically about it's the clinical mission, consistent with the clinical mission, is what you're answering questions about learning disabilities and so forth, or going into classroom. You're still operating clinically, gathering information to help make recommendations for individuals that are consistent with the role as an evaluator in a psychological issue. I was trying to talk about recognizing that you have a clinical role, and that clinical role doesn't mean that you know a lot about things outside of that clinical role. And you need to be very careful about that. The thing that Joe just pointed out about, can the patient, in terms of FMLA, can the patient work or not work? Well, you don't know anything about the work setting, really, other than what the patient told you. And so you really can't answer that question. And we've done many consultations with therapists who have written these advocacy letters to be confronted with the reality that what they assumed they had been told by the patient, as Joe has pointed out, was true. It wasn't true. It was the patient's reality or the emotional reality for the patient, but not forensically true. This is dangerous turf.
Mm-hmm. Yeah. So Joe, anything to add there?
Yeah, when I said outside of the room, I mean, just as a rule of thumb, that if you're asked to say or do something that's going to go to somebody outside of the therapy room, you ought to think, is this a forensic situation? Certainly, an IEP meeting could easily turn into a legal matter if the school does not wish to grant the requested accommodations of the parents and who are relying on your eval to ask the school to do those things. And so, yeah, in that case, it would be. I mean, things like inviting collaterals in, that probably not. That's not going to put you in a forensic role. But if your action is going to go out of the room and affect the patient's life, you ought to think carefully, am I in a forensic situation now?
Yeah, and I think what you're both really talking about is the role clarification. So we as clinicians need to be really clear what role we're in, and ideally not taking on multiple roles or conflictual roles, because the argument, right, per the literature and stuff is that forensic role and role, but there's an actual conflict of interest between those two roles. So I think the issue is performing and not stepping outside that. Jeff, I'm going to let you start on this one just because you talked about it earlier. But if a clinician decides not to write an advocacy letter or something like that, like a disability or FMLA letter, what then should they recommend to the client instead? Can you give some comments on that?
Sure. I mean, if there's an issue that has to do with damages for a lawyer, then the recommendation is that that person be evaluated by somebody retained by that attorney to answer the psycholegal question. Um, know the limitations of what you can do and can't do. Writing, we wrote some articles about writing emotional support animal letters, where that's a very complex area of psychological science, yet therapists would write letters and my patient needs a dog in their apartment. And in fact, they get themselves into significant difficulty doing that. What's the risk? Well, I don't know. Something bad is only bad when something happens. So if a board comes knocking on your door and you've done this kind of evaluation, which is incomplete, not thorough, isn't balanced, you can find yourself in some significant difficulty there. Letting people who do this as a living is the right way to go. And I've said at the beginning, there are gray areas where your advocacy has a good role, which is, short-term emergency disability, no problem. Accommodation for a support animal, I mean, most people don't even know what a support animal is in the law, but they'll advocate for that. So be very cautious about the taking the role out of the therapy and out of the therapy room and extending it into another venue where you're not familiar with the law.
Joe, any additions?
Yeah, what the alternatives are to come to mind: referral to a forensic psychologist or evaluator to do the independent eval, so the therapy remains unclouded and separate from the assessment procedure for whatever it is the patient's looking for. The reality is that that's going to cost money, and I have a feeling that in the outside in the real world, there are people who can't afford that and are going to pressure the therapist into trying to do something. The fallback position might be to provide simply a factual statement and to use the patient's words rather than your own words to describe their condition. They say they can't work. They reported that they got so upset at work that they cried and couldn't do anything for 2 hours. Using the patient's words, using disclaimers so that it's very clear that you say outright, I'm not doing a forensic eval. My patient is my only source of information. I can't tell you that I've done a full evaluation of this issue. That's kind of a fallback position, and if you do it carefully, depends on your risk threshold. Safest thing to do is refer out, but we all have different risk thresholds. So when you know where yours is, the step down, greater risk, but still potentially workable, is this kind of summary that is quoting the patient and goes very lightly, if at all, on your opinion as to what's going on.
Yeah, the summary that's factually based and that lists the limitations of your data, right? That's what you're mentioning.
Right, exactly.
Yeah. And I want to mention, Jeff, to one thing you said, what are the risks? Well, in some situations, of course, if you're going to do something that's relevant to a legal matter, you have to know the law. But, like with the ESA letters, licensing boards have sanctioned clinicians for writing ESA letters that were not supported by data and where they didn't do evaluations. So knowing what has gone wrong or what can go wrong in those situations, I think is really important.
It's a very good point, is that ESA, people don't understand when you write an ESA letter, you are saying that your patient has a disability, a formal psychiatric disability, it's in the law, and that the presence of the animal has ameliorated the symptoms of the disability. Well, most of the people who write these letters never see the patient with the animal. Some do, but most don't. And so they write this advocacy letter, and now they've certified that somebody has a disability, and there can be long-term implications for that individual who has been formally diagnosed with a mental health disability. You need to know the law.
Mhm. Yeah, I think there's a lot of, I hope what you're getting from this is that there's a lot of complexity here. There's no one right answer. There's not one right way to do it. There's probably several wrong ways to do it. And as Joe said, there are ways that have greater risk and lesser risk. So consulting, again, in these complex situations, we highly recommend. Um, Joe, there are multiple questions here again about the suicidal scales. Could you just quickly mention those again, as
Yeah.
well as the safety plan that you mentioned? I think it was the Stanley Brown safety plan, but if you could state those clearly, that'd be great.
Yeah, the safety plan, what is the Stanley Brown safety plan? If you Google it, it's a one-page document. It's excellent. I strongly suggest you do that. The instruments that have some validity for suicide risk assessment, Columbia Suicide Severity Rating Scale, and there's a screener version, so you can use that first, and then if there's a positive finding, move on to the full Columbia. Suicide Cognition Scale revised, the PHQ. Now, I was surprised that this had any validity, but it catches people who are just openly suicidal, and you, instead of asking them, they just endorse it on the form. So, but when they do, it's meaningful. And the Beck, and there are two Beck suicide instruments, Beck Suicide Intent Scale and the Beck Scale for Suicidal Ideation. Also, but again, the thing to remember is that statistically, you're doing this, but it doesn't mean that it's going to be particularly accurate. As I said, it's the best we can do at this point in time. As long as we do the best we can, that's the most we can do to protect ourselves. We may be wrong, but at least we've gone to the effort of inquiring comprehensively and evaluating fully. And that's going to protect you and me in the event of a patient suicide and some action that comes against us as a result.
Yeah, thank you. And I want to just add, as we all know, suicide assessment can be complex, right? There's many factors. So I want to be really clear what we're talking about here are some of those. We certainly don't have time today to train in that particular, but from a risk management perspective, right, this is paying attention to our own competence in this area is really critical. And if you haven't gotten a training in suicide assessment in some number of years, probably a good idea to go back and get an updated training, right? Because the literature and data on this is changing all the time. And it's so critical to our work. So making sure that we're competent and that we reassess our competence, I think is really important. So I just wanted to add that in.
Yeah, if I can throw something in, I entirely agree. I think that having done calls for 30 years, I've been left with a feeling that when a psychologist is dealing with a patient's suicide, they don't understand that suicide is a part of the reality of the world that we deal with. It's something you do need to be trained in if you are dealing with patients and treating patients, and it happens. And when these things happen, it's a major loss. There's no question about that. But it's also important for the psychologist to recognize that they're damaged as well, and to be very careful with that. Be careful about what you say and tell other people. And maybe this is a place where the old rule, if you don't know what to do, don't do anything, really applies. That you accept the fact that this is a reality of the world for psychologists. I lost patients when I treated for years, and our insureds will lose some as well. And it doesn't mean you've done something wrong or that you failed. It means that the patient made a decision to end their life. And then it's the time for what Joe is talking about, good risk management, where you are able to demonstrate that you managed the case appropriately and that you were informed about it. And that's exceedingly important.
Yeah, I think those are good points. And I want to add too, if and when, and we haven't talked much about this, but if and when there is a patient who dies by suicide, right, it's not only the time for risk management perhaps, but it's also really the time for exquisite self-care, right? The
Yes,
clinician needs to get very good support, because not only is it a personal tragedy, but it can absolutely impact how we practice moving forward. It can make us practice in not so helpful ways. So making sure that the clinician gets support is really important as well.
agreed, agreed.
Joe, anything you want to add there before we get a few more
Yeah,
questions?
just to say that, there's a continuum of risk. I mean, and that's important to be aware of, that most psychologists are not going to be successfully sued. Only a small percentage will ever be successfully sued for suicide. Uh, Primarily, people go after prescribers as the target of their anger. Um, so, you can worry too much, perhaps, in the sense that your goal is to follow the procedures, do the best that you can in that way, but try not to, to sort of catastrophize with each patient, because it is relatively uncommon for a patient to suicide. It's like psychologists who have lost a patient maybe have lost one or two, as Jeff said, three patients, but it's not something that is a high base rate phenomenon. So that doesn't mean you shouldn't be diligent in assessing, but you also need to contain your own anxiety when a patient mentions suicide, and not freak out about it. We do get calls like that where people freak out. The answer is just to have your methods ready and prepared to go.
Yeah, and to that point, Joe, sorry, I think that's where competence and continued training comes in. Because if you really do get trained well in this, I think that helps us to manage our anxiety, right? Because then we do know what to do, and we know what questions to ask, and we know sort of where that line is, and when we need to act versus when we need to sit with it, and those kinds of things. So all of those are good points, I think. Okay, so the next question then, what if and this goes back to the impaired provider. I know you both mentioned this, but it bears repeating just to clarify. What if your patient reports an unethical concern about another clinician, and this information is obtained in a confidential session? Is that considered protected and confidential information? So Jeff, do you want to? Oh, okay, Joe, go ahead. Go ahead, Joe.
It depends on the state, on the law. I mean, as I said, there are state laws in some states that say that it doesn't matter whether you're breaching confidentiality. In those states, the determination is that the risk of an impaired professional is so high that it outweighs the confidentiality interest of the patient. If that is not a mandate, then you can't. Then you would need patient authorization to disclose, or the patient themselves you could discuss how they could protect themselves or set things right by filing a board complaint themselves if they feel that that's merited. So you can give your patients information about what to do, and that they can decide whether they want to follow that or not.
Yeah, I think that this is in the spirit of no surprises. If you're in one of those states that requires that you report it, and a patient is starting to share with you that information, I think you have an ethical responsibility to remind them of the law. That if you are told something that leads you to conclusion that there's child abuse, elder abuse, or in this case, an impaired provider, you, by the law of the state, are required to actually report that. They need to know the rules. You can't have surprises in psychotherapy. It's just not allowed.
Yeah, I agree. It should absolutely be in your informed consent, and along with everything else, if there's going to be a mandated breach, if someone says some
Agreed.
particular kind of information. I also, just a quick reminder, and then we're going to close. For when we've all been talking about the laws, if you are practicing in other jurisdictions, please know you've got to know that state's impaired provider law, not just your state. And if you're practicing under SIPACT, the other state is what matters most.